Good afternoon, everybody. This is THCB Gang, episode 17. We are here. We have a great panel for you today. We are going to be seeing, you're just going to, in just a minute, you will be seeing a lot of great panelists that we have today. You may notice something about us, but I'll leave that to the viewer. So joining us today, we have Shannon Brownlee. She's the Senior Vice President at the Loan Institute, a nonpartisan healthcare think tank based out of Boston. We have Grace Cordovano, one of our regulars. She's a board-certified patient advocate. She's the CEO at Enlightening Results, advocating for patients and patient rights based out of New Jersey. Jessica DaMassa, you may have seen her. She is a very familiar face at the healthcare blog. She's the WTF Health host, along with Health in 2.0 co-host, which she co-hosts with Matthew Holt. And she's the it girl of health technology. Jane Sarasohn-Kahn, she's the advisor at Think Health. She's also been named one of the most influential health economists in the world. She'll talk a little bit more about that, and you can check out her blog at Health Populi. Pretty sure I got that right. Jane, if I didn't, please correct me.
Perfect.
And our second guest, Tina, she's a partner at Diagram. They're looking to redesign healthcare spaces to improve healthcare outcomes and really take into the patient perspective. So with that, you'll see their faces pop up in just a second. Hi guys, can you guys all
Hi
see
there.
me?
Hello.
Hey. So really quickly, I kind of want to go through just what everybody has been seeing from their industries or their industry's perspectives. We have a lot of different experts from the field. So with that, I just kind of want to get everybody's thoughts. So Jane, can you start us off?
Sure. I know we're going to talk about the Supreme Court stuff later, so I'll leave that aside for a minute. In my world of consumers and retail health, it's been interesting to know what Walmart's been doing for a while, but this week Walmart had several big announcements, and Walgreens yesterday announced the $1 billion investment in Village MD to bring primary care to the street, to Main Street. I think that's huge in our world. And so it's been a big focus on retail health because I think people are starting to go out and look for healthcare closer to home and not in the hospital setting.
Yeah, I think that's super important, just bringing PCP care right back into the hands of the, I know you said it earlier, the consumer, but the patient, the person to actually access their care. Grace, what are you seeing?
So I'm in Northern New Jersey, and Governor Murphy put out an executive order requiring masks outside when social distancing is not possible. So we are slowly opening, and as someone that is pro-mask and following all of the public health and science, I am so relieved because, as you know, masks have been a disastrous, politicized microaggression and massive aggression space. So I'm hopeful that many others will follow suit and we can start working together as all of us versus the virus.
I really like the term pro-mask, and it totally shows how politicized a movement became when it was about a public health crisis. So we'll be picking up on that a little bit as well, Grace. Jess, start us off. I mean, keep going.
All right, so you guys know I'm very much into what's going on with health technology, and the biggest news in this space right now happened today. Livongo's stock busted through with $100 a share mark, which is huge news for all the other digital health, remote monitoring, virtual care companies that are out there looking at the valuation of that company, worth $10.5 billion today on the stock market. It almost, it was like 5 cents short of 110 at one point. So I'm sure over there they're dying. And Teladoc too, you can't not talk about them. Earlier this week, they cruised past the 200 mark. They were hovering around 230 a share today, and that's huge too. They're worth about $18.8 billion as a company. So, I mean, this is, really, I think, a seminal moment in health technology, digital health, and virtual care, telehealth, especially because these companies are achieving some really big valuations here. Exciting stuff.
Wow. That I just I heard a lot of numbers and like a lot of billions. I really
That's all you need to know. The key takeaway: billions.
It's so crazy when I met Glenn way back when with you and Matthew, and then to just see this company IPO, their share opened at 25 and now to 100, you said. Wow, that is.
I mean, it was up 10% today. So the way the market is moving, I mean, it's just, it's really some pretty astronomical growth.
Incredible. And our two guests, Shannon and Tina. So why don't we start off with Shannon? Can you talk a little bit about what you do just at the Lawn Institute? My gosh, I keep getting this
Lown.
Like, okay, there we go. But can you talk a little bit about what you do there, and then we'll jump to Tina?
Sure. Well, for the last 2 years, we've been pretty obsessed by a big data project that is the Lown Institute Hospitals Index. And what the index is it's a new way of ranking hospitals and looking not just at patient outcomes, which is of course important, but also looking at two other categories, which is civic leadership and avoiding overuse, which has been a longtime interest of mine and also of the Lown Institute. And so we came out with our ranking on Tuesday. We've gotten quite a bit of press about it. And the civic leadership part, I think, is the most important, especially at this time where we're seeing really big inequality in rates of COVID cases in disadvantaged neighborhoods versus, upper middle class and upper class neighborhoods. And we're also seeing real disparities in the hospital's ability to deal with the cases. And so what our ranking shows is that there are really big differences among hospitals in terms of how inclusive they are, how good a job they're doing in terms of really bringing in the people of color, people of lower income and lower education in their catchment areas. So those are the kinds of things that we looked at, and it's, as you can imagine, creating a certain amount of controversy in the hospital world.
I'm
Yay.
sure.
Which is, our feeling is, bring it on.
We got your back.
We got you. We're coming. I was actually looking at the index. It's almost, and I know you worked a little bit with the U.S. News and reporting sort of that.
Well, I used to
background.
work at U.S. News and World Report, so I know how that sausage is made. Their best hospitals report. In fact, the idea for our report started a decade ago with two friends that were also former U.S. News and World Report reporters and editors, and we thought there's got to be a better way to rank hospitals that says, what are hospitals doing for America, rather than, which hospital do I as an individual want to go to?
Yeah, no, and the indexing is incredible. I was looking through it this morning, and you really take into account patient background, safety net hospital, Medicare, like just really giving scores on that, which I think is very different and very new. So I definitely want to talk about that later as well. And Tina.
Yeah, hi, I'm so excited to be on. I've been watching all of the gang episodes, and I have noticed a certain pattern, so I'm glad to be breaking the pattern. So I am a partner, and I'm a partner.
What could she be referring to?
Yeah, so I'm a partner and founder of Diagram, which is a design healthcare consultancy based in New York. And we have been working with various different healthcare agencies, pharma companies, technology companies it's really about improving the patient experience from a design perspective. So we use methods of design research, human-centered research to really bring about these kind of patient insights and stakeholder insights, because the patient is not alone in this, and really helping to translate those insights into products and services for companies. And what I've seen this week is a really interesting kind of move into determining whether or not it's safe to do in-person research. And it's, I think that as things start to open up, people want to be ethical. They want to, have safety be top of mind, and really think about, is this the time? And if we have to conduct in-person research, what's the best way to do it?
Yeah, so a quick sort of theme that I'm seeing is everybody's sort of talking about patient advocacy and sort of the patient activists. And my thoughts behind this is, so with states reopening, Grace, you talked a little bit about this. Tina, now you're talking about it in the East Coast. These hospitals, these clinic, elective surgeries are reopening. How do you protect the patient, and how do you make sure that the patient is protected while they're in these sort of institutions, right? So we had a couple pieces on, airflow practices and patients sitting to, vulnerable patient populations, accessing the healthcare system, and maybe going and getting picking up something that they wouldn't want to. So how do you, Tina, Grace, anybody else kind of wants to come to this, is I guess just starting with that is how do you protect the patient at a virtual and now physical lens?
I'll jump in. So I think right now you need to have your voice. You need to speak up, address what makes you uncomfortable. So I work with patients who have cancer and multiple comorbidities, and there is, rightfully so, a lot of discomfort and a lot of fear and a lot of anxiety, but it can be vocalized. We need to talk to physicians, talk to our care teams, talk to the nurses, talk to the staff, talk with our families, and come up with a plan, because a lot of different things can be done, and a lot of information and credible content can be provided to ease a lot of the anxiety. We're seeing just the simple fact of, well, what masking procedures, bringing a mask, sanitizer, leveraging telemedicine when it's not necessary to come in. Doctors are meeting families outside, literally stepping outside when they're afraid. Blood draws being done curbside. We're trying to get injections and infusions done at home. So there definitely have been many more opportunities to reinvent how we imagine and deliver this care and patient experience that I've never seen before. But it's not going to happen unless you push back, and then push back a little bit more and ask.
So I have a question: is this big push towards resuming elective surgeries, is this being driven by patient need, or is it by the fundamental structure of the financing for hospitals? I mean, this is where they make their money. And so, man, they are ready to start up those elective surgeries again. And is this really the best thing for patients? I don't know.
Mm-hmm. I want to say, Shannon, that elective can be very misleading. So especially in oncology, it could be someone needed their gallbladder removed and now it's gallbladder cancer. It could be a mastectomy with reconstruction that now has metastasized. It can be a hip replacement that now can't be done because there's a fracture or there's an infection, there's been a stroke or side effects over the months from treatment. So I think honing in on an elective where immediately you would think of like a nice to have or like plastic surgery or a tummy tuck, that is not the case in many of these situations. So in many situations, these are necessary life-saving procedures that patients need that got unfortunately pushed to the side.
I do think, though, there is some of that, to Shannon's point about, this is how the hospitals make their money. And I know that there are some companies that are working to help hospitals. Kind of Health Catalyst is the one that comes to mind. I think I saw a press release earlier this week about a new platform that they've launched, where they're a company that aggregates a whole bunch of data from EMRs about what's going on. And so what they're trying to do is help hospitals take a look at their populations and what's happened in the past in terms of some of those elective procedures, and kind of analyze not only which ones make financial sense for the hospital to open up first, but financial sense and also patient sense from a patient safety standpoint and a staffing standpoint. So they kind of aggregate all the information that they've got there to kind of give them a score on what makes sense to open up with first. So
yeah, I guess where I'm coming from is that a heck of a lot of stuff that gets done, it is elective in the sense that there are multiple ways you can treat the condition. And patients are so often not really included sufficiently in that whole decision process. And so, most hospitals are not practicing shared decision-making, which means you have to actually really inform the patient. and make sure they understand what their alternatives are, and then make sure that they're making a choice that's commensurate and that agrees with their values and their own preferences. And so, we know a lot of treatment gets done without the patient really being an actively engaged partner in the process. And yet that's where the hospitals make money, is in those procedures that have alternative possibilities. They're not making money on COVID patients.
Yeah, and just what I picked up from the point you made is financial sense, right? So it's almost
Right.
again treating illness and vulnerability with a cost and a price tag. So how much of that, like how much can the patient, when they're walking in, trust that their intentions are being taken, into account when they're entering, let's say somebody with, Grace said, with somebody with a cancer diagnosis that needs an X surgery, is it safe? But is it, how much money are they going to make off of this body? And I think Jane, I kind of want to get your perspective on this as an economist. How is that changing? Like how did it impact us, in the extreme COVID era, I guess, or the first wave? How is that changing in terms of like a patient landscape in a hospital system?
Yeah, in the first wave, so April Commonwealth Fund did a study on cost as a barrier to looking for COVID care for many people. And this included people making over $100,000 a year. Everybody's worried about cost, even in the COVID era, even when you had symptoms. But the fear of managing the risk of exposure to COVID got in the way. So as I've been saying lately, instead of fear of missing out when we want to be out there, it's fear of leaving home. And so we've got this cadre of people, to Grace's point, a study done on people who did not seek cancer care in the COVID era and put it off. And now, to Grace's point, we will spend more money, let alone possibly lose lives or people being sicker downstream. So, I mean, the cost issue for the healthcare consumer, who is poorly served as a consumer, has not gone away in COVID. We really reveal another aspect of it, which is a real sin in America. We're the only country in the world where patients worry about cost in the era of COVID, preventing people from seeking care when they really need it. Now it's getting clearer in some places. It is safe to go to an emergency room. It is safe to go to a dentist. I went to a dentist a couple weeks ago.
Ditto.
Yeah, I got a mammogram a few weeks ago, which I put off for 2 months. So, I mean, it actually is fairly safe, at least in suburban Philadelphia, in my health system, to get care. But this cost issue has not gone away, and it's even worse now because we have the COVID crisis, we have an economic recession, many people, millions of people still without work, therefore many without health insurance. So we're in this circular situation, which will be very hard to dig out of when we still have threats to the ACA going on. So it is not a happy picture. I hate to be the dismal scientist, which economists are, but I mean, that is the profile right now.
Yeah.
Right. And I remember I had to actually we were at UCSF in Fresno, or one of the affiliated hospitals. And, one of my relatives had an attack, an asthma attack. And I remember just overhearing the PCP saying, the NICU is eerily quiet, and it's, babies still need help. Cancer patients still need access. Everybody still needs access, but everybody's scared and they're putting off treatment. And we don't even know the consequence of that health, what that even is going to look like in the upcoming weeks, or even, we're living it every day, right? Like you said, you put off your mammogram, by 2 months. We don't even know the true impact it's going to make in the year, or within the, towards December, as we head into the winter months. What's going to be the actual impact on our system, and what's going to be the health of our citizens? I think that's huge. Tina, do you want to jump on this a little bit about how healthcare
Yeah, I was going to
outcomes?
mention about with patient experience. I mean, unfortunately, these things have existed before pre-COVID, right? Like decision making,
Yeah.
uncertainty, having to weigh, decisions around that kind of you're being affected by the social determinants of health as well, right? It's kind of like access and being able to get there. And so, I see a lot of improvements with digital health, with telehealth, and all these great things, but there are still these human problems that exist between conversations of doctor to patient, being able to advocate for yourself, even being able to have providers ask the right questions. Are you comfortable with this? Are you okay if I do these things? Because, those conversations aren't happening. And so I think that I hope to see addressing these kinds of issues, because I think that there's something that has been happening for a very long time, and hopefully having kind of this COVID experience now, in front of us for quite some time, seems like it's a good time to address these issues.
Which
No,
brings, yeah, go ahead.
I just
Jane?
want to make a comment about the conversations. So Shannon brought up a point that most places are not doing shared decision making. I have extreme anxiety after what we lived through in New Jersey and New York, watching what's unfolding everywhere, because you're watching this literal train wreck happening. No visitor policies get put into place at all of the facilities because it is a pandemic and public health takes precedence, the health and safety of those in the hospital, the staff, the caregivers, as well as incoming patients. That breakdown in communication, when you have limited English proficiency, when you have language barriers, when you're in the sandwich generation, when you're taking care of the elderly, dementia, disability, to say that you literally have to drop off your loved one curbside and just wait for a phone call, which might not come for days. You might not get up for days. That has to be the definition of hell, okay? As you're living it in the middle of a pandemic and you have no contact. So I encourage using telemedicine to pull in and bring in these care partners and family members, that people should have a plan in place, get those advanced directives in, have these conversations, because in these areas where there's hotspots, there's no opportunity for conversation. And then there's this shock. So I think there's this saying, it's too early until it's too late. And I really stand by that. And I encourage everyone to really amplify that.
So that kind of brings up, we had a piece by Ray Costanani, and he's the CEO of Bright MD, and he was talking about how the Cures Act only everybody rushed to, well, I guess they tripped to implement telehealth services, and then they kind of rushed it. And now it's telehealth services that are live, where the doctor's seeing the patient. But he's sort of calling for coverage of asynchronous care and more care and more practices that involve sort of the home care element with, let's say, can you consult your whole care team versus just the physician and the patient? I mean, care goes beyond just the doctor and the patient. Grace, like you were saying, Shannon, I think you said this a little bit too, it's a whole team of care providers, and how can we bring all of those and empower those individuals into the actual care of a patient? So I wanted to get a couple thoughts on that, because that ruling was sort of in, as we move more into the political sphere, with the CMS kind of coming into that, what are some thoughts on having that coverage? Is it good? Is it bad? Is it ugly?
I can say one thing, that one of the things that we do that's really crazy in the way we care for people in the community, especially older people and disabled people, is, and Jane, I'd love to hear your thoughts on this, is that we don't pay for it regionally. We pay for it by vendor. So you can have in Washington, D.C., 10, 20 different companies that are providing, say, home care services. And instead of that, each company being responsible for sort of one little region or one little neighborhood of Washington, D.C., they're competing for patients all across the area. And so their home care people are going from one house to the next house to the next house. There's a huge amount of travel in between. It's nuts. And it means that it's inefficient. It means that you don't pay these people hardly anything, which is insane. And people in their homes are not really getting kind of consistent care. They may be getting multiple different caregivers coming in and out. And my mother, who lives in assisted living now in Olympia, Washington, which is, you know, she's still in lockdown, isolation. I mean, it really is like being in the isolation ward. She has early stage dementia. So having different people coming into her house would be really disruptive and hard. So can't we just pay for this in a really different way so people can get the care they need? Well, or why don't we pay for this in a different way so people get the care they need?
I also, I hope that, I agree. And I think that I'm hoping that this kind of Zoom, telehealth, the way that we're even meeting with people now can help to flatten the hierarchy a little bit. You know, it's so challenging. In a lot of the work that we do, we're trying to address the mental health as well as the chronic disease or the acute condition or whatever it is together. And in the state that we've been in, it's the mental health has always kind of fallen through the cracks. You know, the clinicians say, that's not my world, I'll let them deal with it. The mental health, specialists say it's, it has to be integrated. And with asynchronous care, is there a way that we can kind of bring that together so that it is more holistic and that there are more people involved, and that everybody kind of has more of an equal voice in the care, really in service of the patient?
Can somebody define asynchronous care for me?
Yeah, I can.
Great.
Synchronous is real-time, face-to-face between a clinician and a clinician or a clinician and a patient. Asynchronous means it could be email, it could be a phone call with a message or a text message to you, but it's not in real time. The study that Zoya was talking about on asynchronous care, and I wrote about this last week in my blog, it was a fascinating study because, to Shannon's point, I'm always thinking telehealth should be real time. That's where the quality is. Well, in fact, the data show that asynchronous really contributes to continuity of care because the whole care team can be messaging each other. There can be a platform with very efficient messaging and a history of tracking. And so I've become a recent fan of the asynchronous. It also leads to lower costs, better coordination, quality outcomes, blah, blah. So there's more data now coming out on asynchronous, which is very old school. It was store and forward, the old kind of telemedicine that existed in rural America before we had the COVID epidemic with hockey stick growth of this. But I think that the fear in all this to the beginning question was that we've opened the Pandora's box of telehealth in all its flavors, and CMS has been so generous at paying at parity, and 50 state laws have come down in the short run, licensure laws. And now some insurers are cutting back on supporting telehealth because it appears that the claims numbers are going up, up, up again, hockey stick, and whoa. And now to be empathetic with that point of view, with the payer point of view, we need to understand what works in telehealth, what doesn't, what patients it works in better, what conditions. And so we need more data, but we have to be careful, that we don't lose the momentum for more virtual care, which is a good thing in general, that people are learning more self-care, more health literacy in care when they can. So, it's going to be a balance, but between now and next spring, you better believe there's going to be a lot of lobbying already with the ATA, American Telemed Association, and others to keep the spigot running and get payment parity, including for telemental health care. Tina, great call out on your part, because most people managing chronic conditions have some level of anxiety and depression anyway. And most of us, after the pandemic of COVID, will be part of a mental health pandemic. All of us, in some way.
Oh yeah. Many headaches and sleepless nights in the last 3 months.
Absolutely. And too much, too little social distancing from the refrigerator.
Tina, I wanted to add, I loved your point about mental health. I just had a patient, she's a cancer survivor, and she went to go see her rheumatologist. She has a lot of autoimmune conditions and chronic pain. And the doctor asked her, well, how are you handling the pandemic and are you stressed? And the patient said that she started talking. She was so happy that he asked, and she got about 30 seconds in and he said, I'm really sorry you're dealing with this, but okay, I'll see you in 2 months. And she was like,
Whoa.
like
Right.
nothing. We have the technology. I still am so frustrated as to why we can't bring it in and normalize it. There is no question that people want to go to help. So now here this patient opened up about something, saw a glimmer of hope, and then just left her high and dry. And now she came home and upset and cried because you know what? The doctor that's been following me for 20 years didn't connect that dot, and I don't know where to go. And I have this fancy Zoom platform that I can connect to anyone, but I don't know where to start.
Right. Yeah, that's
can
a
do better.
really common refrain. We
Yeah.
did work with cancer patients and looking at mental health, and they said, out of all the patients that we talked to, I think maybe 1 or 2 said that their oncologist asked them about their mental health, and what we heard from the providers is always, oh, well, once I asked them, I don't really know, we don't have any, services to offer, and I think that, again, because some of these technology barriers are being broken down by just having to be on Zoom and be on technology. I'm hoping that then people will just know more about what's available to them, even outside of the hospital system, outside of, their kind of common providers that they see.
I mean, that's one of the terrible things about this is that those solutions exist. I mean, there's like
Oh, yeah.
thousands of digital mental health companies that are able to help provide care at a scale unprecedented before and reach populations that might be in rural environments or homebound or whatever. And the problem is a lot of providers have no idea that these things exist. Patients have no idea that they exist. They shouldn't even be asking for them. I mean, there's definitely a huge disconnect between what we have available, ready to go, in terms of digital virtual care kind of solutions that are out there, and meeting the healthcare system, the traditional healthcare system, where it's at with that information so that they can take it and actually get it in the hands of patients who need it. I mean, that is one of the biggest problems with digital health and health technology. For the last 2 years, especially as these companies are trying to grow and scale, it's like, they don't have the visibility. I always say, and Matthew teases me, there's no infrastructure. There's no way for them to get from point A to point B. It's like the highway for that to happen in a quick, meaningful way where everybody gets reimbursed along the way. That just does not exist right now, not at scale.
Yeah.
But it's funny because oh, sorry, go ahead.
Go ahead, Shannon, go ahead.
No, the places where it's been shown to be really effective are places like Kaiser, where they basically have instituted these programs where you can email your doctor, you can talk to your doctor on the telephone, et cetera, et cetera. And, they've found that it actually has saved money, improved care, blah, 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 blah. And yet hospitals don't want to do this because their revenue is in patients coming in the door because of the way we pay. So we have to change so many things simultaneously.
They
to
need
make
to
all
start
this
looking
work.
at this as an e-commerce strategy, the same way that retail stores started looking at the internet as oh crap, we better get an online store. And if you look now at like Shopify's stock, which is like a company that helps smaller businesses set up an online store, it's through the roof during this pandemic because everybody's trying to figure out, how do I take my business and make it digital? Hospitals, this applies to you too. How do you do this? You need like an e-commerce strategy for delivering patient care. And that's where virtual care, remote monitoring, digital health, digital therapeutics, all of that stuff is right there to build that out. And the other thing is, I think they don't know how to do it. And the reimbursement structure needs to be there because of the way our healthcare system is set up. And we need another party to pay for it all. Kaiser's a great example because it's a closed system.
Right.
I'll give you an example that's really old. I've worked in the UK for many years, used to live there. So the NHS, of course, has to budget because they only spend about 7% of their GDP on healthcare, and we spend more than twice that. 12 years ago, I did a cost effectiveness analysis for a CD-ROM-based cognitive therapy program called Beating the Blues. I'm that old. That is now an online program and via an app. Beating the Blues is now first-line therapy. Before you are prescribed fluoxetine for depression, a doctor in the NHS will prescribe Beating the Blues to you.
Awesome.
And it works for low and mid-level depression, anxiety over 60% of the time as a step therapy. before you
Hurrah.
pill. So we look at Kaiser, but we can look at the good old NHS, which spends so little and muddles through really well, adopting digital health, and they're developing a digital health apothecary, much like, is it Cigna who's developing an
Express Scripts has a digital
Yeah,
health formulary, and
that's the one.
CVS Caremark has a digital health formulary. Which
So
makes
that's,
it-
Jessica, that's what we need more of, digital health
Absolutely.
formularies that are tested out so that there's an on-ramp to a doctor in a bundled payment and a value-based payment environment, able to provide Tina's high level of service and a continuity of care. But it all gets back to what Shannon talked about. How are we paid? We can't talk about reimbursement anymore. We got to talk about,
You know, only this industry calls it reimbursement. In every other industry, when you do you a service, you pay me. When I give you a product, you pay me. But in this
Right.
industry, we call it reimbursement.
Right.
It's
Oh,
crazy.
yeah.
It's like, you
Anyway,
owe me something.
Right.
But,
I have to
but
be
in many
reimbursed
cases,
for my expenses.
but in many cases, there is no reimbursement. So I want to just, if I may, for those of you who are on Twitter, there's a very popular TikTok going around, Dr. Glaucome Flecken, who
Oh, him.
had a major catastrophic, really sad emergency, and
Yep.
miraculously, thanks to his heroic wife and the care that he received, he had a cardiac arrest and was
Yep.
hospitalized. And he did a TikTok because so he woke up in the ICU, I think a few days later, had no say in this, right? And has a bill, and I think it's Cigna will not pay the bill because the doctor was out of network. And
Ugh.
he's putting on a skit of the phone call. So he's a doctor, and they're basically saying, well, you know, we do recommend that patients call ahead of time to go over their benefits.
You
I
should
mean,
have
can you
woken up in the ICU and called.
Yeah, exactly.
Right.
what a
this is
PR
the
problem.
norm.
In
This
the
is
middle of your
norm.
heart attack, just sit on
Right.
hold.
Hello,
Right. With the
Cigna?
next available
Yeah.
operator. Yes.
I mean,
Right.
this exact thing happened to me. I had a pain, I threw out my back and had a pain incident, went to the ER, the doctor treated me. Then I got a huge bill that said, well, that doctor in the ER wasn't in part of your network.
This is such,
It-
this is
you're in
piracy.
pain.
Surprise!
I know. Right. It's like, I mean, thank goodness New York State has a great set of, policy around appealing, but I mean, it's absurd. You're not going to stop in the middle of your pain, in the middle of
Right.
your heart attack to say, let me just call my provider, my payer to see if they cover you or you're covered, and I
Are
mean,
you
half
in
the people-
network?
Yeah, right.
That's what you say to the
exactly.
doctor. Are you in network? Because you got to get you got to get those paddles off of my chest right now because to bring me back to life because you're not in network.
Right. And
Jane,
the
I was thinking
expectation
of
that
you.
The average consumer would know that is, it's absurd.
Jane,
Well,
I was thinking of you because I'm reading your book on health consuming, and I'm like, this is exactly why we can't call patients consumers. So I'm so torn about the whole word.
You can say we're consumers, but we're treated shitty. I mean, consumers, ask what's the raison d'etre for Consumer Reports or the work that Shannon's done over the years. We're still consumers, but we're treated poorly. Just because we call ourselves, we're consumers because we're stuck with bills and we're stuck with having to make choices and all of that. But that's why I argue for the phrase health citizen at the end of the book.
I love that.
The health system, we have to
Nice.
have universal care and privacy. So
Can
I
you
want
pimp your book? Can we hear the title of your book? We want to,
Yeah.
because
health consuming. This is the book.
Shannon, show us your book too.
oh God, do I have
You wrote a
copy? Yes, I
book.
do.
Now is
Yes.
the time.
I was just grabbing my Overtreated off of my bookshelf before.
All right,
So,
health consuming. I will go
Health
get
consuming. If you send me your address,
hardcover copy, which is
I'll
about
get you a
1,000 years old.
copy. I'll get you a copy of the book.
Ooh.
That's the book. That's your book.
That's the old
A must
copy.
read book. That is a classic, classic, classic.
Thank
Well,
you. Thank you.
I swear.
If you guys have Amazon links for that, that's going to go in the description for all the viewers. We're going to
Sure.
definitely have it available. So I kind of want to bring it a little bit back. We're all talking about having tech and all these sort of smaller ways that patients are trying to connect with, multiple caregivers and multiple tech platforms available at their hands. But the average citizen, Jane, to your point, the average health citizen doesn't know how to even start, right? There's that gap. So how do you work in that gap? How do you, Jess, as you were saying, there's all of it there. There's all of these tech platforms, everything. How do you, for example, even as a, Grace, you made a comment about TikTok. I'm a millennial, I'm not even on TikTok, right? But then even me understanding healthcare, right? Like how do we address that gap for just the citizen to access? How do we get there? Anybody, Grace, go ahead.
Get a copy of your medical records. I don't care if you can understand them right off the bat. I don't care if you're afraid of them. You need them, and you will find a way to understand them. Ask for help. So having that copy of your medical records from your tests, your imaging, any information, because our patient portals, they're subpar to say the least. You start tracking your health information. You start asking other advocates, other members in your community, you start asking questions, you start looking up words, you're starting to be able to now come up with questions, right? And this is the beginning of patient engagement, being able to say, hey, well, what does that mean? Or wait, I'm not a smoker. I never had 2 pregnancies. I'm a man. This is real. This happens in our records. So diving in and understanding, and then I literally see doctors and the care teams lean in. Like there's a spark of excitement when a patient starts asking, that they've looked, they've seen that there's an interest. And coming up that this is the strategy of your life and your health, you have a right to ask for these questions. And now, as Jane had mentioned, everyone's losing their health insurance because of job situations, which means coverage is changing, which means there's more doctors that are no longer going to be a network. You need those medical records. And I think that's a common denominator across the board if we're going to go in any direction. Because if you don't even know that you've been diagnosed with a mental health condition, because the doctor may have not said it, but it's in your records, maybe you can Google and say, hey, is there a technology or an app for bipolar disorder or for anxiety or for insomnia or for whatever the situation is? You can't start unless you know what you have.
So I want to pick up on Jane's wonderful phrase, health citizens, because I think there are many things that patients and healthcare consumers can do. But I think there are a heck of a lot of things that require that the system really fundamentally change to be able to incorporate them. So for example, shared decision-making that I talked about, it's very hard. I'm a pretty knowledgeable patient. And even I find it hard in situations where I'm really, like I'm really in need. I have heart disease and I've had to deal with a cardiology practice. And I find it hard to force them to really engage me in decisions. And so I think there are many, many situations where the system actually has to change radically in order to make it truly centered on how patients feel, how we care for patients, how we care for communities, how we care for populations, et cetera. And the only people who are going to make that, it's not the system. The system is not going to self-regulate. It is not going to change itself. It's got too much power, too much entrenched power, too much entrenched money. So
are we going to rely on the Supreme Court to do it?
That's a great idea.
Is it time? Is it time to do it? Is it time to talk about it?
Why didn't I think of that? But we've got to be citizens and we've got to be engaged in those issues. And I mean, that's one of the reasons I'm a co-founder of a healthcare activist group that basically brought in doctors and nurses, et cetera, and patients, and we put them together and we are trying to advocate for those kinds of changes. And we have to act as citizens as well as really, good healthcare consumers, as well as really well-informed patients. We have to act as citizens and say, enough is enough. We got to have a different system. We got to change so much about this. But, what's it going to take to really make that happen? I don't know.
So your point, let's talk about what happened this morning, right? With birth control being not declared, as a preventative, not being covered because of moral and religious beliefs by employers. And that is completely revoking, as viewers can see now, revoking the female health citizens' rights. That's a right to your body. And that's not, and how I mean, you know, when I looked at that, I was like, is this one step back? Like you said, it's not going to self-regulate.
Many.
So how do we
Oh, so many. I
so
mean,
many?
I mean,
Well,
so
Go ahead.
the two things I have, you know, I don't know. I want to ask this because we have a very smart group of people, women, but people on this panel. And, you know, I'm looking at this and I'm wondering two things. It's like, number one, how did employers become in charge of making healthcare decisions for us? I mean, this just shows this. I mean, these are like companies, like corporations, like it's an entity that exists legally, right? And now it's making a decision about whether or not something is morally objectionable to it and whether or not it's going to cover it with your health insurance benefit. That's one thing. The other thing I'm wondering is what kind of precedent does this set for other kinds of healthcare that are maybe not gender specific? So let's say, for example, I work in my company is totally anti-vax. Are we going to just stop covering vaccines now because it's morally objectionable to me? There's precedent for this. I don't understand where this ends. So I'm dying to hear some other perspectives about it. So, I mean, what do you guys think about that?
What about Viagra?
Oh,
I was about to say, meanwhile, you can get an ED medication, you know, just walk into the place and just, you know,
Those stay. Those stay.
The whole term birth control is so it's almost misrepresented. It's not just for birth control. It's for women who suffer with PCOS. It's with women who suffer with endometrium problems. It's with people who also take Accutane, right? With women who take Accutane, they have to take birth control. So what does this mean just in terms of women's health going forward, right? And it's also a male problem, right? But what does that mean?
So if there were more unions, do you think that unions would be able to say to their employers, no, you got to cover it? You know, if there are women as employees, can women organize themselves and say, cover it?
Sure.
There was an interesting point brought up by one of my colleagues in medicine about, well, how is this interpreted, Jess? Where does it end? What about other medications that have a treatment-related side effect of infertility, such as chemotherapy?
Yeah.
Is that problematic? Can that be?
DNA is modified. Like if you could say for religious reasons, like I don't believe in playing God and using CRISPR to edit the DNA, even if it produces a life-saving drug at the end of it, could you just not cover that for that reason? Like, I don't understand where, like, this seems so dangerous to me. It like not only, you know, like the precedent that this sets is just, it's beyond women. It just happens to be that it's with contraception first. But, and I don't know, I mean, I've read just a little bit about it, but you know, it's like, I don't understand the full
no logic.
application of that. Yeah. I mean, I don't understand how that's going to set case law precedent moving forward for things and decisions that employers get to decide on. And the religious part of it was scary enough, you know, where it was like religious organizations at first were able to, and now it's extended to all employers. And it's like, not only just religion, but the moral aspect. Because what is morality? I mean, this gets into some crazy, you know, philosophy class stuff from college here, where it's like, what is moral? You know, like, and who gets to decide that? I feel like we got completely, as health citizens, disenfranchised by this ruling. And I don't think that a lot of, I mean, I hate to say it, but I think a lot of people who are of the opposite gender as this group here might be looking at that and being like, yeah, this is a girl problem. But I think like, no, the case precedent that this sets is going to impact families, impact men, impact a wide variety of different kinds of drugs and treatments. And we don't even understand fully how that is going to impact us.
So you're suggesting that the Supreme Court made a bad decision?
I know, how dare I?
All we have to do is get rid of employer-based health insurance.
Well, exactly. That is the basic.
Why are employers
Come
even
on.
deciding this in the first
Exactly.
place? Get out of my uterus.
Yeah.
From a long ago war, you know, we're in another era now. And so we'll come to that reckoning because the country will be in a huge recession well into next year. The Social Security coffers, the Medicare Trust Fund, I I mean, I'm just the most depressing person. You will need fluoxetine after but I mean, the country's going broke. I sit in global meetings talking about the world economy earlier
Oh,
today.
yeah.
Jane, what do you think about some of these, the big, like you mentioned this earlier about what Walmart's doing, where now they filed, they're going to become their own, they filed to become an insurer, a payer.
Medicare,
They're working with a PBM,
That's
with Capital RX. And then you've got all of these other big companies who are doing similar things. Optum is in that bucket. They're working with a PBM. Anthem's got their own PBM. They're obviously an insurer. I mean, so as these companies build these vertically integrated little micro health systems, what's going to happen? Or is that going to do away with the way that we're traditionally funding employer care with employers? Or is this going to be like the next gen of that same broken process? What do you think?
Well, I mean, we have to question the value of employer-based health insurance, and that's
Period.
not going to happen before November, but depending who the next president is and the president after that. The next 4 years after this year, we have to work ourselves out of a huge deficit, which our kids and our grandkids will be bearing. So we don't want that to happen. So there will be heavy taxation, and that may include heavy corporate taxation. Because, you know, the state is going to play a bigger role. State, I mean the government. Has to play a bigger role going forward. The
God,
world,
what's Kanye going to do?
and so, I mean, the Walmarts, the CVSs, they're filling a gap right now because there's opportunity to do this. They may well be the integrated healthcare providers of the future, the Kaisers of the future going forward. That's not going to happen in the next year or two, but this is where things must go. This employer-based system will not survive, you know, as maybe Microsoft and Google wanted to, but growth is in the businesses you're talking about, Jess, small business, which can't afford to cover employees. I'm in the gig economy. I've been in the gig economy 20 years. I couldn't work the way I do, except that my husband has brilliant health insurance.
Yep.
Aren't I lucky? That is how I could have started my business 20 years ago. I mean, it's insane. So I mean, I could buy it on the free market, but it would be a big hit. In any case, that gets to your point. Why should we let Hobby Lobby ruin our lives? I mean, that's the case that started with. And, you know, and damn it, I'm a crafter and I won't walk in that store. And it kills
For you. Good for you. Stay strong, Jane. Stay strong.
Health citizen.
We vote with our feet. Vote with our feet.
No, and I think you get into like morality of things too. It's like, oh, am I more like, when you're looking at the finances, you're like, do I have to pay? Do I have to fork up $50 to $100 for this woman employee, right? Like that's how they're going to be looking at the problem. And
that's the problem. That is the fundamental problem. Yeah.
Absolutely.
It's completely just ludicrous when you see that, and you're like, what? You're really gonna, you know, and then that gets into just what you were saying, the precedent. Like, does that get into now again discriminatory practices for hiring employees, right? Gender bias and, you know, even racial bias. Like, what, you know, with people with higher propensity for certain illnesses, like if you have diabetes, you know, so all of these problems, what is the precedent that it's testing? Tina, did you have something to say? I saw you try to interject a couple times. Do you have any?
I know, and the big blabbermouth kept you out.
No, there's lots of things I could say, but I just, you know, hopefully this will also lead to just more women being in power so that they can make better decisions for their companies. You know, I mean, I don't know. I agree with everything that everybody was saying. I just, you know, you think of something in the moment, you want to just say something. So nothing big.
Bring design thinking into health policy. Like the way you look at the world should inform policy, right?
Right. Yeah. I mean, in the way that we think about things is that, you know, a lot of times we're looking at the wrong problem, right? Is that people think of these really big problems and those actually aren't the actual problems. You know, it's we've been working with patients for a long time and pharma companies, and they always think adherence. That's what they want. And they're not looking at the right problem. That's, you know, adherence has been around for a really long time. And so I think really being able to work together and say like, well, what really is the problem here? And being able to inform policy in that way.
Yes, so that actually, we could go on and on, so, but it kind of brings us to our end. We have about just, you know, a little under 5 minutes left. Before we do end the episode, I do kind of want to go around and ask everybody their final thoughts, just what they think we're going to see in the upcoming week. Maybe just some optimism, Jane, just a touch from you. But you know, it just feels like dread after that passing today in the morning with, you know, the Supreme Court siding with the Trump administration. So just your final reflections. Shannon, start us off.
You bet. So I'm going to indulge in a moment of shameless promotion, because I actually do think our hospital ranking is going to start moving the needle on how we think about hospitals and what we expect from hospitals, and the kind of policy that we build around getting a better system and greater and more population health, better health for everybody. And that promotion is go to www.lownhospitalsindex.org.
Perfect. We will definitely have that in our bio as well.
Great.
Tina?
Super.
I would say that, you know, as we start to think about how people can become more empowered and really take control of their healthcare, that there's a lot of things in place, but as a creative, as a designer, I also think we have to think about how can we redesign some of the things that exist out there. I mean, I think, Grace, you brought up a good point of like just owning your medical record. That medical record could be redesigned in a million different ways. And I think that it doesn't have to be a revamp. It doesn't have to be, and there are groups out there that are doing it. I just want to promote a colleague of mine, Katie McCurdy, who's doing things with Pictal Health, and she's really, and you know, she's fantastic. You know, she's using visualization as a way to talk about chronic disease. And so, you know, as we do think about how to empower patients further, I really think that we also have to think about how can we redesign the existing tropes out there so that communication is just is leveraged in a better way.
Great, thank you, Grace.
I think we're going to start seeing a lot of tough conversations about returning to schools. So we know that this is a massive, massive factor in our economy, on the well-being and education of our children, and also the burden of children not returning to school, what it means for women, their careers, trying to maintain a career while managing the household and homeschooling. We're starting to see those conversations. And I think now that schools are going to be required to release what their return to safely plans are, it will be interesting to see what happens. Are they all going to be mandated like President Trump had said across the board? Can they actually pull funding if they don't when cases are surging? So a lot to dig into, and hopefully we'll have more for next week.
Yeah, great. Jane.
So I am going to end up on us with a smile today, because with the growing dropouts on Facebook ads by big companies and support for Black Lives Matter and really sustained support over the last few weeks, I really see, you know, there's a line item in Shannon's report at the Lown Institute where inclusivity is really important. And as we thought about the Supreme Court ruling, I mean, we think about our LGBTQ brothers and sisters and our sisters and brothers of color and other differently abled people. I think COVID has brought a lot of people together who would be very unlikely to come together. NASCAR, for example. So I'm really hopeful, because while you hear things on the news and we don't want to listen too much to that, I do feel, I'm a girl from Detroit from the 60s, and I lived through the riots as a little girl. I do see and feel something in my gut changing this year, in this moment, with all this dreadful stuff going on, drawing people together. And so I really felt that this week. I'm pretty grateful, even with Supreme Court blips and all of that. I really do feel hopeful.
Great. And Jess.
I like Happy Jane. She's really, but I have to say, I like Skeptical Jane even more. So what I'm looking at, I think for the next week, there's been a lot of conversation around the industry on the B2B side about where some of this government money is coming from and who's gotten it and who's getting it and whatever. So looking at a couple different things, the FCC's rural health program got more funding. Who's getting those dollars? Are those dollars actually helping improve care in rural hospitals? There was a big conversation on Twitter about PPP money and which startups took that. and like they're venture backed. So is that really a cool thing to do? And some of them are in telehealth. Like, did you need? So there's like a lot of conversation, I think, not only, and even PPP money with hospitals, some of the nonprofit systems that took it, or, whatever. And I think there's going to be more questions about, where some of these government funds that were meant to, help and support and aid those who are struggling, who took that money and whether or not it was put to good use. I think we're going to be looking at a lot more kind of, dissection of where those funds went. The other thing I've got my eye on is I think that public health emergency is coming to an end here real quick. And it might be next week or the week after, but what that does is that changes the reimbursement structure around all of the telehealth that's been happening and the remote monitoring stuff. So I know there's movement in Washington on that, but I think that's coming to an end soon. And when that does, what's that going to do to telehealth availability? So those two things, I think the conversation is going to ramp up.
Yeah, and my final thoughts are exactly kind of going along with Jess, is what's going to happen with telehealth in going forward in the future, with everybody sort of rushing to, again, rushing back to their spaces where they've made the most money and trying to get patients back into the door. How's that going to account for safety, as well as looking at, again, the precedents that this is set, that the Supreme Court ruling as of this morning has set for just practices in this country. I'm really interested to see sort of I'm hoping, fingers crossed, the backlash that it's going to cause just in Washington, and just from, I hope employers, again, like Jane, you said, we need to have an end to employer health plans. And looking forward to that, maybe not in the next week, but hopefully in the future sometime. And with that, I would just like to conclude. Thank you again so much for joining us. This has been episode 17 of the THCB Gang. It's the July 9th edition. Our guest lineup, as you saw, was Shannon Brownlee. She's the SVP at the Lown Institute. You'll get a copy, you'll get the link to her book, which we'll have in our description. Grace Cordovano, patient advocate extraordinaire. DaMassa, WTF health host, amazing, just health IT girl, as you heard from her before. Jane Sarasohn-Kahn, she's the advisor at Think Health. You can also check out her blog, Health Populi, that she mentioned, as well as we'll have her book in the link in the description on our YouTube page. And Tina Park, she's a partner at Diagram, which looks to improving healthcare spaces and outcomes for patients. Thank you so much for joining us. This has been, again, episode 17. Catch us next week, again, Thursday, same time, same place, 1 p.m. Pacific, 4 p.m. ET.